Good evening, everyone. I'm Jackie Dominguez, ALF National Senior Director of Engagement, and I'd like to be the first to welcome you to the academic debates presented by Texas. This educational program is brought to you by the Texas Planning Committee, Dr. Marone Boucharab, Ricky Graves, Dr. Najiz Gunn, Dr. Jignesh Shah, Sujal Apadaya, and led by Dr. Rita Lepe, a former debater. We're excited about our topics, proud of our teams, grateful to our sponsors, and honored to have such an outstanding panel of judges alongside our esteemed moderator. We're grateful that you would take time out of your busy schedule to join us and hope you enjoy the evening. This academic debate is being delivered on the Zoom webinar platform and will be recorded. During the presentations, if you have a question, please hover your mouse over the bottom of your screen and click on Q&A. Then simply type your question into the Q&A box. For all other comments and to cheer on your favorite team, please use the Q&A box as well. Again, please note that this program is being recorded and will be available on ALF's YouTube channel for future viewing. As I mentioned earlier, we're extremely grateful for our sponsors. Our national sponsors are supporting the debates across the nation and include national gold sponsors, AbbVie and ASI, and silver national sponsor, Salix. Our national bronze sponsors are Alexion, Mallinckrodt, and Pfizer. Let's hear what our national gold and silver sponsors have to say.
Right now, millions of patients are suffering with GI disorders such as overt hepatic encephalopathy, irritable bowel syndrome, chronic idiopathic constipation, opioid-induced constipation, bowel preparation, and ulcerative colitis. At Salix, we have kept up with these unmet needs for more than 30 years by providing an industry-leading portfolio of high-quality products that address these conditions. Through our dedicated and innovative R&D team, we're also exploring potential new scientific breakthroughs, and we remain committed to important healthcare provider investments in education, charitable grants, and sponsorships. We will continue to invest millions of dollars in patient education and do our best to broaden access to Salix medications, because our mission to improve the care for GI patients continues today. For us, there is no finish line.
We are so appreciative of our sponsors' support. We encourage you to thank them when you visit with them. Without their support, we would not be able to continue to fulfill our mission. I wanted to give another shout out to those who tirelessly dedicate themselves to the liver patients and caregivers, the Texas Medical Advisory Council. They meet quarterly to work with the ALF to provide education for healthcare providers and patients, addressing the unique needs of those in Texas. Look at this impressive list of liver experts. We are so honored to have them guide us as we fulfill our mission. A special thank you to our Texas chair, Dr. Rita Lepe. Before I introduce our moderator, I wanted to acknowledge our technology team, Barb Potter and Karen Irwin, and two new members of ALF's national team, Nancy Clemens and Erica Bowder. We couldn't do this without their expertise. Now it's time to turn the program over to someone who really doesn't need an introduction. He is highly regarded by the members of the Texas medical community and beyond. Please join me in welcoming our moderator for tonight, all the way from New York, Dr. Robert Brown of Weill Cornell. Dr. Brown will be saying a few words about the history and format of tonight's debates, including our interactive audience poll. We'll explain how you can help support the mission of the American Liver Foundation, how you can promote the debates through our social media, and introduce our esteemed panel of judges for tonight's debates. Dr. Brown, take it away.
Oh, thank you, Jackie, and howdy, y'all. Welcome from New York. Had I known it would be on a YouTube channel, would have had my hair done, but regardless, it is really my pleasure to be here to moderate the Texas debates. I've done the New York debates, I've done the Chicago debates, so I'll be in good hands to tell you whether you're doing better than the rest. But everybody knows in the great state of Texas, it always is bigger, even if it isn't better. So the academic debates have been hosted by the ALF for 18 years, since I was in high school. We are honored that the academic debates have been recognized for its excellence, has become a signature program of the ALF, and then adopted by the AASLD. The topic and teams tonight were selected by the ALF's Texas Medical Advisory Council that Jackie highlighted on the last slide. Tonight, it is our pleasure to present two debate teams. Each team features, as is usual, two young investigators, usually fellows, mentored by a senior investigator. Each team will debate opposing sides of their assigned topic. It is worth noting that the topic and positions were assigned randomly. Presenters will be sharing a PowerPoint, and then we'll have 8 minutes to present their case. Team members will present their rebuttals, but have no time to do a PowerPoint, and will have 5 minutes to off the cuff state their argument to support their case based on their the points made by the opposing team. Each speaker is closely timed. If they exceed their time, they will be muted. I've seen it before. It's horrible. So remember that, debaters. Keep to time. And the Q&A will happen at the end. The panel of 3 liver experts will do the Q&A, and it should last 5 minutes. There is no right or wrong answer to this topic. However, if you disagree with me, you're wrong. And there may be strong opinions for one side or another that surprise you in this country right now. Strong opinions, lack of data, lively debate, hopefully non-personal. We do have criteria for the team members to focus on, and our judges will focus on both the quality of the presentation, their rebuttal skills, and how they support their position, and hopefully really their ability to debate, not what they think is right and wrong. when we do this live, it is incredibly interactive and fun, and we're trying to make it so in the virtual format. We do not have the chat function, but you can use the Q&A function down in the bottom right of your Zoom screen to write-in questions, and hopefully the judges will answer them. Finally, we really want to acknowledge the hard work of our teams. Though we will appoint winners, everybody benefits from doing this, and express our appreciation to all the people who spend time doing this. Obviously, we need our financial sponsors, but the judges, the timekeepers, the technology team, all of our volunteers who all put their time in on their own time. You can hear I'm trying to do this and juggle, watching out for my young daughter. I know everybody takes time from a busy life, and we will recognize them all at the end. But this is a fundraising event, and the ALF is in an important fundraising time. We are celebrating our 45th year. The pandemic has been hard on all of us. It's been especially hard on not-for-profits that depend on live events to do their fundraising. But it has really been important that the ALF has continued to do their work during the pandemic, to provide support for our patients and provide resources and adapt to the virtual environment. The resources provided include the literature and information on the website, but the ALF has shifted to a virtual environment to try to unite the liver community. We've done virtual walks, I think a virtual marathon. I cooked, you could see it on my Instagram page for Cuisine for a Cause. It actually did taste quite well. I think that was not me, that was the excellent chef. And we've had online educational programs, which have really been excellent. But it has been associated with increased demand. There have been increased calls to the helpline needing help in this virtual environment. And we know that the ALF has continued to really be a staunch advocate for the people suffering from liver disease. And as a not-for-profit, they rely on donations. So please be as generous as you can, provide some support. And if you're in New York next week, we have the ALF Gala. Actually, this week, 2 days. Got to get my tuxedo dry cleaned. You can see me with Sanjeev and Deepak Chopra. I've known Sanjeev for 30 years. I've never met his brother. I'm looking forward to it. But if you can't make it to New York in person, the anniversary gala is available as a live stream. And you can tweet about how good I look or how good the debate is tonight on the debate's Twitter feed at ALF Debates. So before I introduce the topic and the team members, I'm going to introduce our outstanding panel of judges. These judges will join us at the conclusion of the debates, ask questions, and then at the end, tell us who won. Here are our panel of judges. First, we have Dr. Maya Balakrishnan from Baylor. We have Dr. Carlos Dunker from Perspectum, and Dr. Nadej Gunn from Impact Research Institute. Thank you, judges, for joining us this evening. I look forward to hearing what you have to say. So let's get to the business at hand. Our first debate, NAFLD-NASH. Should liver biopsy be used in clinical practice? The pro side, we should biopsy patients, is going to be done by the Houston Methodist Hospital team. And the con, we should not biopsy NASH patients in clinical practice, from UT Health San Antonio. So before we start the debate, we have a quick poll. Based on the criteria I just read, do you feel we should biopsy NAFLD-NASH patients in clinical practice? Please respond yes or no. Should be right in the middle of your screen. I'm voting right now. All right, I'll give you a few seconds and then hopefully it'll pop up and I'll see the answers. If not, I'll blame the technology team. They're tough, the oh, here we go. So it's close. It's right now we have 40% say yes, we should biopsy patients in clinical practice. 60% say no. We'll see if our debate teams can shift that to either more no or to the other side. So let's introduce the debate teams. So presenting the position, the pro position that biopsy should be used is the Houston Methodist with Dr. David Victor, hoping to be a victor today. As the mentor and the fellows, Dr. Michelle Jones-Pauley and Dr. Zunirah Ahmed. The next, we have the con team. The con team is from UT San Antonio, who say biopsy should not be used in clinical practice. Juan Echavarria is not available tonight. He is doing something really important. I have no idea what he's doing. But he got his stand-in, who probably is his boss, Rita Lepe, who is the chair of the Texas MAC, I believe. And with Rita, we'll have Dr. Tamneet Basra and Dr. Pranav Sharad Penninti. So we're going to start with the pro position. Dr. Ahmed from Houston Methodist. She will present her position. Sorry about that. I'm terrible with pronouns. Timekeeper ready? Dr. Ahmed ready? You can begin.
Why biopsy for NAFL? So firstly, as we move with this debate, it is important that we recognize what are the definitions. Per ASLD guidelines from 2012, NAFL is hepatic steatosis by imaging or histology without other etiology for hepatic fat accumulation with no significant alcohol consumption, no competing etiologies for hepatic steatosis, and no coexisting causes for chronic liver disease. On the other hand, NAFL is steatosis of the liver involving greater than 5% of the hepatic parenchyma with no evidence of hepatocyte injury, and NASH is presence of 5% hepatic steatosis with inflammation and hepatocyte injury with or without fibrosis. As we become clear on these definitions, we realize that NAFL is a spectrum of liver disease. Here in this diagram, it's illustrated that if a healthy liver is exposed to the following risk factors for obesity, diabetes, hypertension, dyslipidemia, it has a 15 to 30% chance of progressing into NAFL, which is the hepatic steatosis with no evidence of hepatocellular injury. And then from there on, 12 to 40% of the patients progress to NASH, which is hepatic steatosis plus inflammation and scarring. Once the patient reaches the NASH level, 15 to 25% progress to cirrhosis. And from there on, you can see that in cirrhosis, 50% of the patients can progress to can go for a liver transplant, or unfortunately, they die. And 7% of the patients can develop hepatocellular carcinoma. By 2020, NASH is projected to overtake hepatitis C as the leading cause of liver transplant in the US. Here, liver biopsy becomes the gold standard for identifying the presence of steatohepatitis and fibrosis, and it helps in identifying this patient population of the NASH category where the liver damage is still reversible and we can act early before they progress to cirrhosis. NAFL and NASH is the most common cause of liver disease in the US with a prevalence of 20 to 30%. It is estimated that 25% of people have NAFL worldwide. It's the most recognized in 5th to 6th decades in life. 1.5 to 6.5% of US has NASH, and NASH is expected to rise 63% by 2030. And modeling indicates that NASH will be responsible for 800,000 deaths by 2030. These numbers are very worrisome. NASH is a rising epidemic and definitely calls for an action right now. Currently, for evaluation of NAFL and NASH, we have serum biomarkers and scoring systems available, which are highlighted in this table, including the NAFL fibrosis score, FibroTest, FIB4, ELF, and so forth. We have for these scores, sensitivity, specificity, positive predictive, and negative predictive values, which you can see over here. What I want to highlight is their positive and negative predictive value. For all these scores, you can see the positive predictive value is very low and a high negative predictive value. which basically translates in the fact that these tests can identify patients with advanced fibrosis and can exclude them, but they're not able to identify patients who are in the intermediate stages of fibrosis, which is definitely a large percentage of the population which we are missing with these tests, and only liver biopsy can identify them accurately. After the serum biomarkers, we have imaging modalities that are available as a non-invasive tool for screening for NAFLD and NASH. We have ultrasound, which is definitely low cost and has a broad availability. However, it has low sensitivity in individuals with steatosis less than 20% or a BMI of more than 40. It is observer dependent and influenced by fibrosis and iron overload. MRI is not affected by obesity and can assess steatosis all over the liver, but it's expensive, time-consuming, device and operator dependent, and not suitable for patients with implantable devices. Transient elastography and continuous attenuation parameter has emerged as an immediate assessment tool that can be used in an ambulatory clinical setting, but again, it has limited sensitivity, low accuracy for quantifying steatosis, and uncertain cutoff values. CT scan can visualize the whole liver and can quantify moderate to severe steatosis, but it has low sensitivity for low grade of steatosis and has radiation exposure. How are we managing NAFLD currently? So weight loss is the most important tool that we have for the management of NAFLD. This is a study that was published in 2015, which looked at patients with biopsy-proven NASH who underwent weight loss and looked at the histological improvement in their NASH activity. Here you can see that a weight loss of 3 to 10% was important in improving the steatosis to fibrosis staging. And only less than 10% of the patients were able to achieve the fibrosis of less than 45%. 30% of the patients were able to achieve a weight loss of more than 5% that helped with the ballooning and inflammation. This is important because it recognizes that if you're able to identify patients at an earlier stage of steatosis and ballooning, we can help them more with their weight loss and they can achieve their goal better as opposed to when they reach a higher fibrosis stage. Bariatric surgery for NASH has also been looked at as a therapeutic modality in patients who are morbidly obese and for whom weight loss is not sufficient. This study looked at the bariatric surgery in patients with biopsy-proven NASH before and 1 year after the surgery. So in figure A and B, it's highlighted that the NASH inflammatory activity grade and the distribution of NAS improved significantly after bariatric surgery, but fibrosis did not improve significantly, especially in stage 3 and 4, where it was 7.5% before and remained the same. Again, when patients reach an advanced stage of fibrosis, bariatric surgery cannot help them, and at that stage, it's futile for them to undergo bariatric surgery. And if we identify them earlier, we can help them better. There are different medications that are in the pipeline for the management of NASH, and all of them are undergoing trials currently and are basically on biopsy-proven NASH. So it's important that we biopsy the patients so that we can give them other therapeutic options apart from weight loss to help them with their management. So the advantages of liver biopsy in conclusion is prognostic value, ruling out other etiologies, and also all current pharmacological therapies are based on histological diagnosis. It's important to highlight that yes, there are disadvantages of liver biopsy. It's expensive, but if you compare the cost of a liver biopsy, which is $1,500, to a liver transplant, which is $500,000, that's way more. So it's important that we biopsy patients earlier and help them before they progress to liver transplant. The complication rates overall are less than 1% based on the Halsey trial. There are also mimickers of NAFLD like Wilson's disease, disorders of lipid metabolism, drugs like amiodarone, methotrexate, corticosteroid, celiac disease, and TPN, which can only be recognized by a liver biopsy and not by other modalities that I've mentioned earlier. In conclusion, I would like to mention that NASH is hiding in plain sight in the NAFLD spectrum, and only liver biopsy can help us identify that and not any other markers. Thank you.
Sorry, I had a little delay. I was out trying to book my patients for liver biopsy. It was so convincing. I'm ready to go out and biopsy and look for that fox. So let's see if the con presentation from UT San Antonio can get me to cancel all those biopsies. Who do we have first? I think we have Dr. Penninti. I hope I pronounced your name right, Pranav, from UT Health will try to convince me, now that I'm fully convinced that biopsy is necessary, that we should not be doing biopsies for NAFLD-NASH in patients with in clinical practice. Go to it. The timer is on.
Thank you to the American Liver Foundation for giving us the chance to be here. Really excited to be here with you all this evening to discuss this great topic. And so our position today is that biopsy is not needed to stage NASH. So just a quick introduction about why this is such an important topic for us, but NAFLD is the most common cause of chronic liver disease in the world. It's the second most common cause of liver transplantation in the US, and it affects a quarter of the global population at this point. So clearly this is a disease with a really heavy clinical burden and something that we as hepatologists need to be paying close attention to and lending our expertise towards. We have a schema on the right showing the natural progression of this disease course. So we have initial steatosis, progressing to steatohepatitis, to fibrosis, advanced fibrosis, and cirrhosis. And we need tests that are able to accurately discriminate between each of these stages. And we need that for a couple of different reasons. One is to prognosticate where patients are in the disease course. Two is to manage the potential complications of this disease. And the third is to assess for impact of our therapeutic interventions. And so when we come to this, the gold standard, as has been discussed, is what's been the liver biopsy. And so we have a couple of different things that we think are inherent flaws in the biopsy as a gold standard. So one is that an adequate liver biopsy only represents 1/50,000th of the entire hepatic parenchyma, so a tiny sliver of the liver. And we have a study over here by Ratsu et al. And we looked at, they looked at two percutaneous liver biopsies from the same patient from the right hepatic lobe, and it was read by the same pathologist. And the preservation in terms of fatty change was pretty high between both samples, but fibrosis stage was actually different in up to 41% of the cases. And a kind of similar study was done in patients who were undergoing a Roux-en-Y gastric bypass, and they took concordant biopsies from the same patient, one from the right lobe, one from the left hepatic lobe, and they saw that there was a difference in stage in 30% of those patients as well. So what this shows us is that one, we're getting a tiny sliver of the liver parenchyma, and two, NASH is a disease with high heterogeneity in terms of how it affects the liver tissue and how it's distributed. I'm going to quickly touch on this, but 50% of liver biopsies in this country are done without imaging guidance at this current time. In South Texas, especially, our BMI on average is above 30. And so there's potential risk for high risk for poor patient-related outcomes as a result. And some of the complications are as follows. So pain can occur in up to 22% of patients. And when you actually account for mild pain, that number increases to 50%. Major bleeding rates are low in the range of 0.16%, and those come in the form of peritoneal bleeding as well as hemophilia. Death is obviously a very rare complication, 0.03% of cases, and usually driven by a major bleeding event. So as we alluded to earlier, we need tests that are able to discriminate between the different stages of NAFLD-NASH. But the main thing that we need to be able to do with the test is to be able to discriminate between the presence or absence of fibrosis. We looked at several different studies, and this is an example, but this is a longitudinal study that essentially delineated groups with NASH versus without NASH, and they looked at several different variables. But as you can see over here, our line on the yellow, our yellow line on the graph shows us patients NASH without fibrosis, and the red line is patients with NASH with fibrosis. And there's a clear demarcation in terms of their survival in the Kaplan-Meier curve. And the study showed that the only prognostic factor associated with liver-related events was fibrosis, not the NAS score, not any markers of steatosis or steatohepatitis. And so we're at the point now where we've diagnosed our patient with NAFLD or NASH. The next step is to stage our patient. How much do they have fibrosis, one, and do they have advanced fibrosis, two? So what other modalities do we have that are less invasive than a liver biopsy, and how do they compare to a liver biopsy? So the first group of tests that we looked at were just our classic serologic composite tests. So we have our NAFLD fibrosis score, our BARD score, our FIB4 score. And what I want you to focus on is the negative predictive values. And so this is quite high across the board amongst all these scores. And what this tells us is this is a great initial screening tool to exclude advanced fibrosis. Not the best tools to actually to rule in advanced fibrosis, but a good initial screening tool. The added benefits are they're cheap, easy to use, can be followed longitudinally, and can be inputted at every clinic visit. The next test is the transient elastography, also known as a FibroScan. And so we looked at a study with 274 patients, and the area under the curve in terms of detecting significant fibrosis was quite high for the FibroScan. So for F2 fibrosis, we have 0.84 area under the curve, for F3, 0.93, and for cirrhosis, 0.95. And you can see a quite high sensitivity and specificity as well with the FibroScan. The benefits of the FibroScan over liver biopsy are, again, cheap, easy to use, widely available, extremely safe, and we're actually getting a more global assessment of the hepatic parenchyma than a liver biopsy does. When we look at our MRE PDFF, so this is our next couple slides are going to be dedicated to MRI-based technologies. And so we look at our MR elastography and PDFF, which is a proton density fat fraction. And so the elastography will give us a sense of stiffness of the liver, and the PDFF gives us a sense of steatosis. And the PDFF has actually been shown to be a more robust method of measuring steatosis than even biopsy. And if we look over here at our, it actually had a pretty good sensitivity and specificity for diagnosing advanced fibrosis. As an added benefit, MRE showed a high accuracy in discriminating patients with NASH from those with simple steatosis as well. This is a study that was just published about a month ago in Clinical Gastro and Hep. And so they looked at patients, they did an MRE in patients with simple NAFLD and then NASH cirrhosis. And they showed that for each 1 kilopascal increase in liver stiffness by MRE, non-cirrhotic patients were 3 times more likely to develop cirrhosis in the future. And for each 1 kilopascal increase in liver stiffness by MRE in NASH cirrhotic patients, they're 32% more likely to develop a decompensation event or die in the next 5 years. And so another benefit that this shows us is that the ability to prognosticate, longitudinally follow these studies, and to help dictate further surveillance intervals going forward. Another MR-derived biomarker is the multiscan. And so this is also known as the CT1. It's based on tissue regional water content, and it helps assess for active inflammation and fibrosis. And so you see over here a good Spearman's coefficient when we're looking at correlation with ballooning, inflammation, as well as fibrosis. This is now covered by insurance. We had a quick patient example we wanted to go over. And so we had a patient of our mentors who lost about 40 pounds over 6 months or so. And the benefit is we have real-time data that showed a drop in the CT1 score, as well as our PDFF. So the fat fraction dropped from 30% to 7%. We look at cost over here, and a marked increase in cost when looking at elastography versus liver biopsy, almost 4 times the cost when you're looking at those 2 studies. And so our take-home points are that liver biopsy is not needed to stage NASH. Liver biopsy is no longer the gold standard and has many inherent flaws. Non-invasive tests are able to distinguish between the presence and absence of fibrosis with high fidelity and can be tracked longitudinally. And novel imaging modalities are showing good promise in discriminating between steatosis and steatohepatitis. Thanks for your time.
Oh my gosh, now I am perplexed, a true clinical conundrum. Do now I have to cancel all those biopsies and book MRIs? And does my liver actually smoke? So hopefully we'll get some clarity from the 2 rebuttals. We're going to start with the rebuttal from Houston Methodist, Dr. Jones-Pauley. All right, Michelle, let's see if you can tell us that for me to reschedule all the biopsies that I canceled in the last 8 minutes.
Well, I'm Dr. Pauley, coming at you from Houston Methodist, and I hope to address some of the points that Dr. Penninti just educated us on. So he mentioned that any fibrosis in NAFLD or NASH is important. Unfortunately, currently with our non-invasive measures, even with the best sensitivity and specificity, they're not designed to really pick up lower stages of fibrosis. Currently, all of these tests are actually based off of histopathologic evaluation of this disease process. So for the argument against biopsy in terms of sampling error, I think that's inherently flawed because all of these tests are actually compared to the gold standard right now, which is, of course, liver biopsy. In terms of actually equating importance or weighting importance of the stages of fibrosis, McPherson et al. Compared the paired biopsies in 108 patients with both fatty liver and NASH in 2015. spanning a median of 6 to 7 years. And they actually showed progression of both diseases, so that'd be fatty liver as well as NASH, to fibrosis in 42% of patients, no change in fibrosis in 40% of patients, and actually regression only in 18%. So I think this pretty clearly illustrates the need to identify the stage of fibrosis and even the liver fat content. Because as Dr. Ahmed alluded to earlier, it's actually more impactful to intervene earlier in this disease process. And if we're not catching this disease process earlier, that'd be with either F2 or less stage of fibrosis, or even just fatty liver, then we actually can potentially catch this disease a little too late and have these patients progress to fibrosis and eventually cirrhosis. And with the current projected mortality of around 800,000 patients from NASH in 2030, I think it's imperative that we address this disease earlier in its course. In terms of complications, as both Dr. Ahmed and Dr. Penninti pointed out, most of them are less than 1%. In the HALT-C trial, where 2,700 Hep C patients were biopsied using the percutaneous method, the bleeding rate was about 0.6%, with an overall significant adverse event rate of 1%. And that includes everything from bleeding, pain, punctured viscus, pneumothorax, syncope, and dehydration. So although there are risks, it is a relatively safe procedure. Pain by far, of course, is the most common complication. It occurs about 84% of patients, as described by Eisenberg et al. In a study looking at percutaneous biopsy. In a study conducted by Juan et al. In 2016 that looked exclusively at transjugular liver biopsy, they looked at 341 patients and found that major intraperitoneal bleeding occurred in 2 out of those 341 patients. So that's roughly 6.6% These patients were treated using transcatheter arterial or venous embolization with a favorable outcome. Death, though incredibly uncommon, does occur. It's usually due to a fatal bleeding episode. Occurs in 1 in 10,000 percutaneous and in 9 in 10,000 transvenous biopsies. But it's worth noting that these fatal bleeding cases are most likely to occur when biopsying a highly vascular or malignant lesion. So that doesn't particularly apply to our target population. The prognostic implications of accurate staging are of utmost importance because surveillance for HCC, complications of portal hypertension, in addition to rationale for treatment, depend on this accurate knowledge of the position of the patient's liver along this disease spectrum. The accurate staging is currently only obtainable by liver biopsy, which is the gold standard. In summary, biopsy is relatively safe, more sensitive and specific for diagnosing NASH or fatty liver, and is the current gold standard by which all non-invasive testing is measured. We're fighting a battle against an invisible enemy and are facing the need to identify patients earlier in this disease process.
Told you they were serious about turning off the mic, but I think we got the key points from Dr. Pauley, and now we'll turn our attention to our last rebuttal. I'm still up in the air. I don't know which way I'm going to go. So Dr. Basra, here's your chance. Get us over on the anti-biopsy.
All right. So just to target some points that the other team made. Number one, they did talk about the FIB4 and the other non-invasive testing modalities, saying that the negative predictive value was high, but that the sensitivity specificity was low. And that's basically the same argument that we made, is that these tests are very useful in ruling out advanced fibrosis. However, I think all hepatologists, all specialists would argue that you don't use just one test in practice on its own. And so most hepatologists will recommend that you combine these modalities, these non-invasive tests, with other concurrent imaging. We need to focus on kind of our population in Texas. So we did also talk about how the imaging modalities are still cheaper than the liver biopsy. They did make a point to say that the imaging MRIs and things are expensive, but at the end of the day, it's still less expensive than the liver biopsy. They did also mention that the risks are minimal and that the risk of death is very low. However, we argue that one risk or one death is a death too many. And we have to keep in mind with our Texas patients, these patients, like we mentioned, have a BMI of greater than 30 on commonly. Patients that have NASH are women that are overweight. And so these complications, although reported in literature throughout the nation, I think these percentages would be a lot higher if we had just done a population study within Texas. The bleeding risk, the risk of pneumothoraces, all of these things add cost. So if this is a patient that has a complication and you're in a clinic setting, these patients then have to go to the ER for blood transfusions, for admission, for further monitoring, and that obviously adds additional cost. The availability of ultrasound and imaging technology is not available at every single center. We mentioned that 50% of biopsies are still done by radiologists for a reason. We know that procedures done under imaging guidance, such as ultrasound, are safer. And then we did also, they made a note to mention that diagnoses such as Wilson's requires a biopsy for formal diagnosis, which we would disagree with. Wilson's can be, you can do genetic testing to diagnose certain conditions. So just to reiterate some of our points, liver biopsy does have a high discordance rate with pathologists. There's a lot of performer variability depending on the number of procedures that hepatologist has done, and as well as resources available within their clinic. Ultimately, non-invasive tests, like we mentioned, should be combined with other imaging modalities. We've mentioned a few like the FibroScan, which can be done anywhere. FibroScans are now done at fairs where they test patients and have patients risk stratified so that they're encouraged to follow up with hepatologists for further workup. Multi-scan that we talked about is something that's arising in literature, and Dr. Andreas and Harrison et al. Had published a study in January of 2021, basically noting that the CT1 version of the multi-scan correlates very closely with changes in inflammation, as well as fibrosis, and the PDFF portion of it correlates very closely with ballooning. And the last point I want to make is whether these things that we are all discussing today will change management of the patient. Ultimately, the person sitting across from you in clinic, the patient is who you should target your studies towards and your interventions. So once we've ruled out advanced fibrosis with the tools that we've mentioned, it's that middle gray zone with F2, F3 patients that we target. And so these patients, like we mentioned, lifestyle modifications, pharmacotherapy are the options. However, our example in our PowerPoint illustrated that the multi-scan does a really good job in not only correlating the change in fibrosis, ballooning, inflammation, but it also acts like a motivating factor. So this patient, after 6 months, was able to get another multi-scan, whereas repeat biopsies over and over again is not always practical and not always available in clinical practice. So I think at the end of the day, just for closing statement, we need to focus on whether what we are ordering and what we are doing is going to change the ultimate outcome. Thank you.
I am truly impressed, and I'm going to start to have my patients fly down to Texas to get an MRI. I've never seen an MRI that's only $500. I don't know where you're coming from, but be that as it may, we've had some really strong points. Before we start the Q&A, there is a link to donate to support your favorite team. It's in the Q&A section. I hope you'll link. I think you can also support your favorite moderator. There's only one, but maybe we'll get $1 here and there for the moderator. But we'll begin our Q&A. Let's bring on our 3 judges. We were introduced to them earlier. Dr. Balakrishnan, Dunker, and Gunn. Who of you would like to ask the first question? Maya?
Yes, absolutely. These were Wonderful debates. I have a question for UT Health San Antonio. It's wonderful that you brought up our population here in Texas. It's true, most of our patients with NAFLD have obesity or morbid obesity. On the one hand, that does make liver biopsies more difficult to conduct and possibly increases the risk of complications. But on the other hand, elastography techniques can be confounded by severe obesity. And, you know, when patients get their first evaluation for NAFLD, that sticks with them. The message you send them with that first diagnostic test, that first stratification test really sticks with them and will shape their motivation for lifestyle change possibly. So, you know, given that, how do you respond to the potential inaccuracy of elastography findings in our obese to morbidly obese NAFLD population here in Texas?
Pranav, I can take that. So you're absolutely correct. That's a big limiting factor of the FibroScan, but MRI basically works around that. So MRI, PDFF, as well as the multi-scan can be used in obese patients and are found to be accurate in these patients. Again, these are all imaging modalities that you can repeat. So because NASH is such a big issue in our population, I agree with you. These are patients that we need to watch very closely to see if they even do well with our lifestyle intervention and pharmacotherapies. So these are patients that you do want to see back in clinic and then eventually follow them longitudinally with you know, modalities like MRI or multi-scan to see if there's any regression in their fibrosis.
Does Methodist, do you have a response?
Yeah, so MRI is not available at every hospital. They mentioned that elastography can be done at a fair, but MRI cannot be done at a fair. You have to be at a very, you know, an academic place to do an MRI. Then MRIs, yes, can be done serially, but as I mentioned, the cost of the MRI, cost of an MRI is around $1,400, ranging to $1,600. And if you are looking at serial MRIs every 2 to 3 months, because at your first assessment, you were not too sure about, you know, what's the disease status, I think an MRI is overall much more expensive than doing a liver biopsy at the initial assessment and making a diagnosis of NASH at that point.
Hey, Dr. Gunn, looks like you're ready to ask a question.
Sure. So I think you both teams did an excellent job, well presented. I'll play devil's advocate here. Dr. Basra did mention that you have to look at the patient in front of you and make those judgment calls. So this question goes to both groups. In what scenario would you change your position? So you're a pro or a con, but you have to have some reason to change your mind. And I'd like to hear some scenarios in which your mind would change. You could take it UT and then take it to Methodist.
All right. Yes,
sure.
I think that.
First.
Okay, go ahead.
Okay.
Go ahead.
You know, I was going to say, I think the scenarios where I think a liver biopsy is indicated would be kind of in those gray zones like we discussed. If there's an unclear diagnosis, if we're concerned about autoimmune hepatitis, or if there's other kind of etiologies of liver disease that we're thinking about. With regards to purely staging the disease, I think our position is that there's enough alternative modalities out there at this point that we feel comfortable that a biopsy is not needed purely for staging purposes. So again, I think the major indication from my standpoint about needs for liver biopsy is more so to tease out an etiology if there's concerns for other concomitant or alternative explanations for the elevated liver enzymes.
Thank you.
So yeah, in scenarios where I would do like non-invasive testing as opposed to a liver biopsy is obviously looking at the patient socioeconomic status. Again, like at this point, yes, the cost of the liver biopsy is more. And if the patient has risk factors in terms of the established risk factors for NAFLD, where we are not like 100% sure, but maybe more than 90% sure that it is non-alcoholic fatty liver disease, and we're not missing out on any other etiologies where they already have the established risk factors. In that cases, yes, maybe I would go with non-invasive testing using the serum biomarkers or the imaging and not pursuing the liver biopsy at that point.
And then, of course, you always have the patient's preference in mind. So if they're deathly afraid of needles, you have to take that into account.
Thank you.
Deathly afraid of the result. That's why I've never done a FibroScan on myself. Dr. Dunker.
Congratulations to both teams. Recently, a Swedish group published in GOT a paper with more than 10,000 patients followed for 30 years, showing that even isolated steatosis or non-fibrotic NASH are associated with excess mortality from extrahepatic cancer and cirrhosis. Does this make you think that assessment of the NAS and not only fibrosis is important? I'd like the Methodist group to answer this first, please.
Yeah, I think our entire argument actually hinges on that point. It's important to not only identify advanced stage fibrosis, which we're well equipped to identify currently non-invasively, but it's also important to identify where along the disease spectrum these patients are. As we pointed out in our presentation, we have a higher success rate earlier on in the disease, and this ultimately translates into decreased progression of the disease to fibrosis and cirrhosis.
And UT San Antonio, please.
Absolutely, because I think if you have a patient that has more steatosis than fibrosis, you may approach that case very differently than someone that has less steatosis, more advanced fibrosis. In clinical practice, so far when I've seen patients in my own fellows clinic, even if they have stage 3 fibrosis, we watch them very vigilantly to make sure that they don't progress to stage 4, because that becomes a concern with decompensation events and HCC screening that they need to be followed very, very closely, because I think that's kind of where the lack of follow-up happens, and then they develop malignancy and then metastatic disease, which of course leads to bad outcomes.
I'm going to ask the last question. One answer per question. Come on now. So first I'll ask the con side. That if you say we shouldn't biopsy, don't you think that some of these therapies that are going to be expensive, in which the efficacy and safety was only developed based on biopsy parameters, you're going to be ready to just put them on those therapies for long times without knowing that their histology matches, both in terms of minimum and maximum severity of disease, that which we saw in the clinical trials? Brief answers, please, from one of you.
Sir, I think that's a great point. I think the data that we saw, especially for the multi-scan, is showing that there's high concordance between the multi-scan images that are resulted and features of steatohepatitis. So, and they're even starting to use this more so in the clinical trials, especially with the added benefit that you can longitudinally follow these scores as opposed to just getting liver biopsies. So I think this is an important thing to be able to follow, but I think that the newer imaging modalities are hopefully going in that direction going forward.
And Dr. Pauley, because I can see you straight there in the middle and you haven't answered in a while. Your patient is in front of you. They know what they have to do: lose weight, take a statin, control their diabetes, no matter what the biopsy shows. Why wouldn't you defer the biopsy and just let them do that and only biopsy the ones whose liver tests don't normalize?
Well, I think everybody deserves a fair trial, a fair therapeutic trial, obviously. But as you pointed out, kind of their response to that trial needs to be assessed. So I think that biopsy is warranted in these cases just to kind of track their progression, their natural disease progression or regression, hopefully, if they're following their treatment protocol and they're doing it successfully. And it will allow us to either be more aggressive in our treatment regimen or kind of allow us to adjust treatment strategies based on what their biopsy is showing.
Excellent. Well, one thing I'm glad is I'm not one of the judges, because this is going to be tough for the three of you. So thanks to all four of our debaters. But before we conclude this debate, we're going to have a follow-up poll based on the presentations. So remember, did this presentation change your opinion regarding whether or not you feel we should biopsy NAFLD NASH patients in clinical practice? Don't focus on what your opinion is, but did your opinion change? Yes or no? Let's give it a vote. Well, pretty close. Our judges are going to have quite a time because 58% didn't change their mind and 42% did. And I don't know if they went in which direction. We don't even know because we started pretty close. So our judges are going to have their work cut out for them. And I look forward to seeing it at the end. And we are halfway there. We're halftime. No, we don't have any cheerleaders. We don't have a dancing squad. We don't have a band, but we do have great sponsors. We have AbbVie and Eisai, our gold sponsors, Salix, our silver sponsor. And though I don't know if colon preparation is actually a disease, I think you should correct that in your next video. Alexion, Mallinckrodt, Pfizer, our national bronze sponsors. Thank you to all of you for doing this. And please remember, we need to have you donate. Look in that Q&A box. Get us towards that $5,000. The link is here. Support your favorite moderator, your favorite team, or your favorite judge, or your favorite sponsor. Really don't care. Let's get us up to the limit. And when you're doing that, please stay to the end. We want to announce the winning teams, and we're gonna move along. So while we're doing that and making our donations and waiting for the judges, there are future debates. One of the nice things is that you can watch debates across the country from the comfort of your living room. So we have Arizona, Utah, and Texas. Texas already occurred. They have a second debate on November 3rd. It's like the way they vote. We have the Rocky Mountain debates on November 9th. I think I'm going to be at that one. Greater Pennsylvania, November 30th, and then Greater DC area, December 2. So we're going to congratulate all of our teams. They really have done a great job. Their mentors have done a fantastic job. I also want to thank the ALF tech team, including Queen Barb, who kept me on task. And all of you for joining us this evening. So the winner of tonight's debate is UT. Thank you to the team. You can take a bow, you can smile, you can show us your family. Great job, but I must say that everybody has really done a fantastic job. And remember that, the mission of the ALF is education. It is research. It is patient education. Encourage your patients to use those resources and participate as broadly as you can in the ALF mission. For you physicians, young physicians, remember to join the medical advisory committee when you become faculty, wherever you go. And many of the wonderful things that we do. The Cuisine for a Cause is fantastic. I always like doing the liver life walks with my patients. It's nice for them to see you outside of the regular event. And then, of course, we have the gala this week. See Deepak inspire us and me wear a tie. So follow us on social media, like us on Facebook. As my daughter says, like us on Facebook, give us the thumbs up, and on Twitter and Instagram. I hope you've enjoyed your evening, and thank you all for spending this time with us.
Thank you so much for your expertise in moderating, and thank you to our teams and our judges, and of course to our sponsors. We look forward to seeing you next year. Think about your team for that year. We are looking forward to planning our 2022 academic debates, and we hope you all join us. Have a great evening, and we can't be more grateful. Thank you.
Oh, and just in case, go Red Sox.